There you go. Okay, so Dan, I'll put the slides back up and you can get started.
Great. Okay. So if you had been arriving at Bromley by Bow today, whoops, we're jumping through.
This one.
Yeah, then you would have arrived at a building that looks like this, or in fact, a cluster of buildings, a campus really. That stone arch was actually, it came from Northumberland Avenue originally. It was designed by William Kent, and then was part of a very, very ancient building that was knocked down to make way for a new school. And Bromley by Bow has used this stone arch to create the entrance into our courtyard. So you'd have been arriving there this morning. As you can see, not an NHS sign in sight, deliberately no NHS signage at Bromley by Bow, in fact, very little signage whatsoever. There was that comment about how do you reach people and how do you let people know what's going on. And we largely, we do have a website. It's a very, very full website indeed, but we're aware that for communities like ours, particularly deprived communities, human contact is really probably the best transmission mechanism and best way of reaching people. So at Bromley by Bow, deliberately, we have no signage, but we have a lot of staff on hand. And if anybody looks lost as they're coming into the courtyard, a member of staff will stop and ask them what they're looking for and how they can help them to get where they need to go to. Great, okay. And so today we're going to talk about the kind of the values of Bromley by Bow, its history, our model, and some of our thinking for the future. So if you'd come to Bromley by Bow sort of 36, 7 years ago now, you would have encountered that photograph in the top right. In fact, you can see that arch there, very, very right at the back of top right. That was after it was taken off the ancient building that was knocked down to make way for a school. It was literally plonked on the back of an East End church. That's the back of the East End church there. And in the foreground, we have a very scrappy and ill looked after local authority, 3-acre local authority park. That's the scenario that Andrew Mawson, who's now Lord Mawson and very famous in the world of sort of social regeneration and social entrepreneurship. Andrew Mawson arrived in 1984 to encounter really a 200-seater East End church that had, times had moved on and the church, quite frankly, hadn't. It had a tiny little congregation who were in the church for a couple of hours on a Sunday morning and a few £100 in the bank. And apart from that, an extensive set of church buildings, which had sort of, leaking roofs and squelchy floors when it rained. And they were almost entirely locked up through the whole of the week, except on Sundays for a couple of hours. And Andrew's really a very interesting character. He's actually the son of a Bradford milkman and trained to be a telephone engineer originally before he got the calling and studied theology at Manchester University. And he's a very sort of plain, kind of interestingly spoken person. And Andrew said, faced with this scenario of these sort of 12 old folk rattling around in sort of pews that were there to accept about 200 parishioners on a Sunday morning, he said they were sitting scattered across the pews. He said it was as if the dead had been taken out, leaving these 12 old folk behind. And history had really moved on. East London had gone through huge levels of well, it's always been the poorest part of London, but it had gone through massive decline after the 50s and 60s with the closure of the docks. 100,000 jobs disappeared, a bit like a mining village, but 20 years earlier, and it wasn't a mine, it was the docks. And dwindling population, half of the houses in Tower Hamlets were empty, nobody wanted to live there. And there'd been then mass migration from Bangladesh in the 1970s, really refugees fleeing the war in Bangladesh at the time. And nobody really wanted to live in Tower Hamlets. As it was said, anybody who could have got out really had got out. So Andrew talks about what do you do when you're faced with a situation like that. And his wonderful turns of phrase include things like loitering with intent, which of course we had to explain to the Minister for Health for Singapore, who visited us a couple of years ago, in Britain is actually a criminal charge. So Andrew walked the streets, getting to know local people, getting to know the streets, getting to know the history of the neighborhood, and meeting people and talking to them and getting to know their names and their children's names and their likes and their dislikes and the things that they found hard, and also getting to understand what their passions were. Andrew effectively went into partnership with the community, flung open the doors of the church with the blessing of the congregation, and invited the community in to come and set up what was the beginnings of a health and wellbeing hub. And within years, we had a little cafe. Andrew met a woman on the street, actually, who said she got chatting, and she said she'd always wanted to run a cafe. Now, neither she nor Andrew had ever run a cafe before, but Andrew trotted off to Wales in a van and came back with a second-hand Rayburn cooker, and it was installed in the church, one of the church buildings. And we set up a small cafe. We set up gardening groups in the perimeter around the church. We set up wonderful art groups. There was a lot of empty housing, as I mentioned, and there was these short life housing co-ops for artists who didn't have studio spaces. And Andrew offered them studio space in exchange for creating a cultural program with our community. This coincided with that euphemistic program called Care in the Community, where people with social care needs and mental health issues and disabilities were being dumped on housing estates with almost no care whatsoever. And we set up a care program for these people, partly because we got wind of the fact that local people were wondering who these slightly odd characters were who were being dumped in their midst with little explanation and very little support. And we thought, let's broker a relationship between these people with disabilities and the local community. Let's set up a social care program. Let's get our artists who've got studio spaces now in the church to develop a social care program. And let's bring a group of young mums who we got to know because they were dropping kids off at the school gates over the road and popping in for a cup of tea in our new cafe. And we got to know these mums that all left school quite early, hadn't got qualifications, were now starting to look for something to do. Many of them had suffered huge amounts of social isolation, living on the top floors of tower blocks as single mums with children. And so we created an NBQ training program and started to train them up in social care, got the artists to design the social care program, and invited in the people with learning disabilities and physical disabilities and mental health issues who are being dumped on local housing estates. And so we created a win-win situation for everybody. And that's in a sense how Bromley by Bow has worked. Spotting a need, spotting an opportunity, spotting the passions, and thinking about how you bring those together with the resources that are controlled and owned by the community, which in this particular point of our history was the church. In all of this, there was a fairly spectacular failure of primary care in Bromley by Bow. One of our volunteers, she was a volunteer, Jean Biles, she had a couple of brothers who had learning disabilities, and she was coming along with them to that program that I've just described. Jean was diagnosed with cancer, and pretty much every bit of the statutory system that should have looked after Jean and her family failed her in her final months. Jean was also the mother to young children and the carer to her two older parents as well. So she was one of these kind of pivotal East End women, if you like. As I say, pretty much everything that should have happened to her didn't. You know, social services lost track of Jean and her family. It turned out in the inquiry into the circumstances of Jean's death at the Royal London Hospital that Andrew attended, that the single-handed GP had changed his fax machine but forgotten to tell the hospital, so the faxes from the oncology team never came through, so the discharge of care into his care never happened, and so on and so forth. But the flip side of Jean's life really was that her fellow volunteers, some of whom had been schoolmates of hers who'd lost touch with her since, but were all volunteering in our social care program, rallied around her. There was a piece of paper put on the wall and a rota to help Jean with things like her washing, taking it down to the laundrette, or some respite care with her parents or her children. People volunteered to accompany her on her oncology appointments and so on and so forth. And this kind of got us into thinking that this notion that community in East London had died with the Blitz was just complete nonsense. But what communities did need were resources to manage for themselves, to develop their own programs together, to come together and to create the future for themselves and to tackle some of their critical issues together. And this has really got us into thinking also about the function of primary care and the poor quality of primary care that at the time was being given to our community. And we vowed that our community deserved better. And we vowed to set up and build a health centre. Now, lo and behold, at that point, the greatest opposition we faced came from the National Health Service. It transpired that the National Health Service had never heard of communities building health centres before. And indeed, we may be the only health centre in Britain still today that's been built by its patients and rented back to the doctors. It was only when Andrew persuaded Brian Mulwiney, the then Minister for Health, to come and visit this small emergent community hub. I'm talking about 15 years into our journey at this point, that Brian Mulwiney really understood what we were on about. And he gave, and in fact, he instructed the local Strategic Health Authority to talk to us about building a health centre. But it wasn't the Strategic Health Authority that built the health centre, and it wasn't the NHS, and it wasn't the doctors. It was the patients who built the health centre. We borrowed nearly £1 million from the Norwich Union, as it then was, Aviva today, and we built a health centre for our community. And then we set about finding some GPs who, in a sense, understood Michael Marmot's thesis about a decade before he wrote it. And we found those two GPs, wonderful GPs, Julia Davis and Sam Everington. Many of you will have heard of Sam Everington. Julia and Sam had a small practice about a mile to the west of Bromley by Bow in a very similar part of East London. And they really understood the relationship between people with health needs and the socioeconomic needs that people had. And as Julia loves to say, you know, it's absolutely pointless me talking to my patients about blood pressure or cholesterol levels if the most pressing issues are putting food on their table or paying the rent, or their child has just been excluded from school, or whatever it happens to be. You know, those things will always take precedence over looking after your diabetes or whatever it happens to be. And as she said, therefore, I need to be part of a wider team. I need a team that deals with people's social needs. I need a team that builds and strengthens community. And I need to be part of a team like that as a GP and as a general practice. And that's really what Bromley by Bow is. It's the amalgam of general practice with a community hub. Today, of course, we've kind of built out from the church a very, very extensive set of buildings, a new community centre, and we still use the church as well, and the church hall and the church buildings, but we built a much larger community centre, and we built a health centre, which is that curved building that you can see there in the photograph on the bottom left. And in building this, which became the first healthy living centre in the UK, we persuaded the local authority to gift us the park on a 30-year lease. I think we paid them £1 for the lease. And we set about tearing up the concrete and the tarmac and creating a beautiful 3-acre facility. But really interestingly, we built the centre into the park. So we created a seamlessness between the streets, the park, a series of courtyards and cloisters, and interjoining walkways between the different buildings that are the centre. So we created a 3-acre campus of health and well-being in which the exterior space and the interior space work together and are as important as each other. So the park is a beautiful community facility now with loads and loads of activities taking place in the park itself. And our buildings are completely open. We have no press button entry systems, no CCTV cameras, no signing in, no signing out. You can enter the building and wander across the building completely freely without ever walking past the reception desk whatsoever, because it's owned by the community. It's the community's building. And so there's a real shift of power. There's a real shift of control between institutions and community at Bromley by Bow. Great, Berenice, let's go on to the next slide, please. So we often liken Bromley by Bow to a community department store. Of course, it would be absurd to think that you needed an appointment to go to John Lewis, and you certainly don't need an appointment to come to Bromley by Bow. And Bromley by Bow is not just about meeting need, but it's also about opportunity and passion and interest. So Bromley by Bow isn't only a place you come to when you've got a problem or something that you need solving. It's also a place where you come and do art. It's a place where you sing and join choirs. It's a place where you garden. It's a place where you come to a beautiful cafe and have lunch with your friends. It's a 3-acre park where you can sit and read a book or play football in, or do some gardening in, or there's a children's playground where you can watch your children play on the swings or whatever. So it's not just a place where you come to when you've got a health issue or need to learn English or got a welfare benefits issue or trying to get a job, but you can do all of that at Bromley by Bow as well. But it's a place where you come to because it's part of your life, it's part of your neighbourhood. So it's owned by the community. Accessibility is everything at Bromley by Bow. Completely open access, lots of welcoming staff, significant outreach programs. So one of the queries was, how do we tell the community what's going on? And whilst I think websites do have a limited benefit, and of course under COVID they've become more important, the truth of the matter really is that it's human networks that really help people to understand what's going on. Bromley by Bow has about 12,000 users a year who come to our non-clinical services, and they are all ambassadors for Bromley by Bow. Every client that comes into an ESOL class, every client that's given the opportunity to freely use computers, or if they need to freely use a telephone and make a phone call, or come and sing in our choir, or learn mosaics, or help to set up a social enterprise. And we've helped about 70 people set up social enterprises that now turn over about £6 million a year and employ 400 people. They're completely separate, independent from Bromley by Bow. But all of these people are ambassadors for Bromley by Bow. Your customers are your best ambassadors in terms of selling yourself to your next set of clients. And so, but we also have outreach teams. We have outreach teams who work on housing estates. We have a wonderful program called Communities Driving Change that works in some of our most deprived housing estates. These are community builders, asset builders who are working in those. I mean, we just had 2 fantastic summer fairs on 2 of our really deprived housing estates. One with about 450 people a couple of weekends ago that was completely organized by the community. And that's the result of about 2 or 3 years of work with that community, with outreach workers. In another neighborhood, we had 250 people who turned up in the pouring rain for a summer fair. And they had organized that summer fair, again, an area that we've been working in for about 2 or 3 years now. We would argue that the greater the level of deprivation, the more the contact needs to be brokered by human relationships. But we also have a wonderful thing called E3 breakfasts, which are run by our social prescribing link workers, and they are for the frontline staff of organizations in our neighborhood. And that attracts about 30 or 40 people who come and have breakfast together. These are all frontline staff from different organizations, housing associations, community centers, et cetera, et cetera. And they all come together to network and share what they're doing, and then they can cross-refer clients from one to another. And that helps to build these connections. So accessibility is really important. Relationships, building strong relationships between professionals and each other, and between professionals and community, and community and community. That's really what we're in the business of doing, is relationship building. And then the last analogy that we have around the department store is probably the most obvious, the range of products and services that we have. I mean, most of us will have had the experience of walking into a department store to buy one thing, and a few hours later coming out with more bags than one can practically carry, full of things that we didn't even know existed, let alone that we needed. That's the experience of coming to Bromley by Bow. So you come to Bromley by Bow to learn English, and a few months later, you might find yourself on the stage in the National Theatre in a production of Pericles, for example, with community members and professional actors on stage at the National Theatre in the South Bank of London. That person who came in to learn English had no idea that that's what they might come away with, that experience of learning how to act with professional actors and being on stage. But that is Bromley by Bow, because we call Bromley by Bow a place of possibility. So you can come in and there's 50 different things you can do at Bromley by Bow. That's our area. That's actually the primary care network area, bounded by the canal at the coming diagonally down the bottom, and Bow Road at the top, and the river coming down the right-hand side, and the river coming down on the left-hand side. So that is our primary care area. We manage 4 of the GP practices out of the 6 in that primary care network area. And that's about, in total, the primary care network's about 53,000 people. So a community hub, medical practice, and then the team that Berenice and I are in, which is called Bromley by Bow Insights, which is a research and evaluation team. So researching and evaluating and defining our model and redefining our model and rethinking our model has been something that Bromley by Bow has been doing for the last 35 years. It's a very, very kind of co-produced process with community. We have community researchers at Bromley by Bow. These are local people who are trained as researchers and managed by professional research teams to become our local community researchers. And then we support innovation within our Bromley by Bow model. And then the program that Berenice runs, which is about sharing our ideas and our model and exchanging ideas with others from the UK and around the world. Okay, if we move on to the next slide, please, Berenice. So that's an aerial view of Bromley by Bow. I've sort of described already the array of services that we have. That's, you can see the curved building there, the blue building, which is the health centre, and the church behind it, courtyard entrance, the cafe, the connection zone, the art studios, the barn, where we have a multitude of activities in the barn, and so on. One of the things to point out, of course, is that when Bromley by Bow built the health centre 22 years ago now, social prescribing was at the heart of our model. The idea that clinicians would have a completely different type of consultation with patients to the traditional one. It's not a biomedical consultation, it's a consultation that talks about social needs and social issues as much as health issues, and then referral to social prescribing link workers, who then refer on to our own services, but also to about, I think, about another 130 organizations every year. So we receive referrals from across the primary care network, of course, and we've been doing that for over a decade now. Actually, we expanded our social prescribing scheme to cover the whole primary care network, which we've had primary care networks in Tower Hamlets for about 15 years now, I think, or so, or maybe 12 years. So we cover the whole 53,000 patients with social prescribing, all of the 6 GP practices, and we have 7.5 social prescribing link workers for our primary care network, which is well above the average. I think the average in England at the moment is about 2 link workers per primary care network. And 2 of those, one of those social prescribing link workers is a mental health social prescribing link worker. And another one is also a hybrid role. So she's both a welfare benefits advisor and a social prescribing link worker as well. If we go on to the next slide, please, Berenice. This is interesting for those of you who are familiar, I'm sure actually this audience, you all will be, with the terms primary, secondary and tertiary care. We've really rethought these at Bromley by Bow, and we'd suggest that, you know, the NHS, what does it spend? Of 130 billion pounds the NHS has, I think less than 5% goes on preventing illness, and about 95% goes on treating people who are already ill. We think that that relationship really needs to shift, and this diagram really explains that. So, you know, primary care needs to be thought of as the individual and the support that they get for themselves around their own choices. Secondary care is primary care plus family and friends and really close relationships. Tertiary care is the 2 below plus community and everything that's there within community. And in a sense, NHS is there if everything else has failed already. So, you know, the whole point of NHS is really its failure demand, isn't it? It's demand of people for whom things have gone wrong, but we need to prevent the things from going wrong. And it's in this diagram, it's primary care, secondary care and tertiary care are the preventative parts of the health paradigm, if you like. If we go on to the next one, Berenice. So driven by values, Bromley by Bow, be compassionate, have a friend, have fun and assume it's possible. We think these are the values. I mean, our chief exec loves to tweet on a Friday afternoon, although he hasn't done for a while yet, but lately, but he used to love to tweet. The great thing about Bromley by Bow's values is that they work at the weekend as well, because these aren't work values. They're not, you know, we did one of those exercises where you look at institutional values and you come up with all this sort of nonsense about honesty and integrity and Lord knows what. And, you know, and then people find those really quite hard to understand exactly what they mean and how they should drive their professional behavior. So we wanted values that would drive professional behavior. And these are our values that our team could live in its daily interactions as a staff team, with our volunteers and with our community. So, you know, in a sense, we're all givers, aren't we? All of us on this session today, we all feel we are givers. We're in professions that are caring professions that are giving, but we need to receive as much as we give, in a sense. You know, it's our lives as well. Coming into work in the morning should be fun. It should be about having fun. We should rethink the relationship between, you know, this idea of co-productive relationships means that we need to rethink the professional relationship. We need to move away from this idea of the professional and the client or the patient. We need to move to a co-productive relationship of equals working together. And that's where having fun and being a friend comes in. Compassion. Many of our systems in Britain have lost their compassion, and we need to build back compassion. We need to build back compassion in the way that institutions work with communities. And this last one has been our strapline for almost forever, really, assume it's possible, which is Dr. Sam Everington likes to say, if you're not tearing up the rule book, you're probably not doing the right thing. So we need to, or to put it another way, think of Einstein's law of insanity, which is going on doing the same thing again and again, and expecting a different result. So if we really want to tackle deprivation and health inequalities and all those other things, we need to do things completely differently. And that's what Bromley by Bow is all about. And we need to continually question ourselves, how differently are we doing things? So principles, Public Health England, the Wellcome Trust and the Health Foundation funded several years of research at Bromley by Bow with embedded researchers and community researchers. And this is the kind of principles that we've distilled from that, many of which I've already mentioned, but built by the community, run by the community. It's not just about meeting need, it's also about creating opportunity. The permanence on the landscape and the longevity of relationships is absolutely critical. I mean, we grew out of a church that had been around for well over 100 years. Primary care actually has, one of the features of primary care is that it's long-term relationship with communities. It always has to be about being creative and having fun. And as I mentioned before, connection and relationships are the main thing that we're doing, or the main mechanism of what we're doing. And being the voluntary sector, we sit, as we like to say, in the messy middle. That's one of the strengths of the voluntary sector, which is why we believe that we probably can't transform health and social care or the way local authorities work, actually, unless we massively involve the voluntary sector and communities in that process, because otherwise these things just revert back to type. They revert back to a deficit-based model of treating illness or treating social need, rather than a kind of an appreciative inquiry model of building on strengths, strengths and asset-based approach. Next slide, please, Berenice. So part of that research was to understand how we might measure the Bromley by Bow Centre and the Bromley by Bow model. And so we did an amazing piece of research with our community. And I'm still to this day struck with the oddness that this seems so novel. But we, in the delivery of services in the UK, we measure a whole lot of things that we as government and as policymakers and as systems leaders and designers and as practitioners that we believe we should measure. So it might be cholesterol levels, or it might be levels of unemployment, or it might be levels of qualifications in a community, or the levels of indebtedness, or it might be, the people's BMI readings, or whatever it happens to be. But we never ever stop to ask the community, what matters to you? What do you think matters to you? What makes a good life for you? And therefore, what should we be measuring? What do you think we should be measuring? And these are the outcomes that our community said were the most important things. We asked them, what are the ingredients of a good life? And they came up with this. So we set up now a set of outcome indicators at Bromley by Bow, which we're just beginning to apply. NHS England's very interested in these outcomes, as is public health. And we're sort of sharing this knowledge. The Health Foundation actually funded us last year to do some further work on this. So we're measuring the degree to which we build people's capabilities and resources. We look at how we meet basic needs, and this absolutely goes to Maslow's hierarchy of needs: food, money, shelter, all of these things, absolutely critical. How we build capability and capacity and opportunity, how we create opportunities for people to flourish, how we create opportunities for people to contribute. People do not want to be passive recipients of services. They want to be part of those, the provision of services, co-producing services with people, bringing people into the delivery. We have a community that runs the Bromley by Bow Centre, for example. Our communities learn absolute shed loads of really interesting skills and capacities through the process of learning how to manage the charity, which is the Bromley by Bow Centre, and how it's run. Connection to others. People absolutely crave and want connection. And of course, we live in a society where social isolation is very, very prevalent. So, this is a really important thing, how we build and strengthen resilience and networks, and how we create a role for people, and how people want to be connected to their communities, not just to individuals, but to the place they live in. People want to be recognized in the communities that they live in. So how we build people's roles and people's recognition within communities is also really important. So these are the things that we're now measuring. We've got a whole indicator set that sits behind these 6 outcomes now. And what's, I think, remarkable is that very few organizations ever stop and ask the people that they're working with, what do you think we should measure about what we do? Berenice, have we run out of time?
No, we've run out of slides for now.
Okay, we've run out of slides for now. Okay, fine. Yeah, okay.
So in a minute, we're going to show you a little it's like a virtual tour of the center. So we've got a lot of pictures of the center because obviously we're not there today. So we'll show you some pictures and walk you through in a minute. But I want to take this opportunity to ask if there are any questions at this stage about the model, the principles, the history. So yeah, feel free to unmute yourselves if you want to ask a question now.
Oh, can you hear me?
Yeah.
Can you hear me? Yeah, awesome. Sorry, you still can't see me. Yeah, so basically, I'm joining a GP practice next year, and they're about to move from their current practice to merge, or at least be in the same building as another practice. And I planning on building a new primary care centre, and also want to have extra space for community services and things like that. I think the main difficulties, as far as I understand, are issues around, it's a more standard, GP model and build. They're just leasing a new building from a primary care building company, which I think makes it complicated in terms of re-renting the space to community services. And even things like district nurses and whatever that would be great to have in the building their levels of funding mean they can't afford the rent levels that it would cost to lease the rooms back to those services. I guess the way that it's worked with you guys is that the community bought the building and they've rented the space to the doctors, and therefore they can decide what they think is appropriate, and it works in that way. I was just wondering if you're aware of any ways in which it can work if the community hasn't bought the space and the land already to allow more community services to be involved in the primary care space, or if there are other ways to work it from a financial perspective.
Yeah, I mean, I think you're pointing out a really tricky conundrum, really, and we're actually working with on the building of 3, possibly 4 very, very large new health and wellbeing hubs. These are, I don't know, £25 million buildings, I guess, something of that nature. But they're being built from scratch as community hubs, as health and wellbeing hubs. One with a local authority in London, one with one of the new towns, in fact 2 new towns, and maybe another one which is a redevelopment of a hospital site as well. And there are different aspirations for all of them, but they all want to have, one of them will have a leisure centre in it, for example. And actually, in terms of the footprint, it'll be largely a leisure centre and community centre and GP practice. One will probably be a mix of local authority services like families and children's services, and the adult learning provision of a local authority, and welfare advice, and general practice and community space. So these are being designed from the bottom up, and these are, one of them's already is nowhere near being built yet or designed, but it's still been talked about since 2013. Another one, these healthy new town ones, both of those have been in planning already and design processes for already the last 4 years, and they're not going to be built or open for at least another 4 years, if not more. So these are long-term projects, but they are being thought about conceptually, and they write models of care. You end up with a model of care that understands that 70-80% of health outcomes are generated socioeconomically, and 10-20% of outcomes are generated by doctors and nurses in the NHS. And so they are based on models that understand what drives health and well-being, and therefore try to look at one of them is aiming to have a footprint of the general practice will be a bit like Bromley by Bow, about 30% of the space, and 70% of the space will be community provision. But of course, the point that you've just asked is how does this all get paid for? And the answer is we're working really hard on these programs to actually to understand how to pay for them. And I don't have an answer for you yet on that, and they're very different projects to the one you just described. I can also point you to half a dozen buildings in London that are really attempts to do something different that have completely failed. You know, there are ones where, you know, you've got library, gym, library, leisure centre and a GP practice, and literally you just walk into an atrium, and then you've got a choice of going left for the library, straight ahead for the GP practice, or right for the leisure centre. That's about as far as the relationship goes between any of those. You know, and there are dozens of buildings like that in London where people have co-located things, but nobody's thought about the model at all, quite frankly. So it's very tricky. The scenario you describe kind of makes one's heart sink, I guess, really. The ability to change that. And obviously, there are a whole bunch of property developers who build buildings for primary care, who just build kind of bog standard, you know, primary care buildings, and you know, and then you're left with this situation that nobody can afford to move into them except for GPs. And you know, that's not an uncommon scenario. I don't know what the answer is. I mean, the answer is enlightenment, but you're not going to get a hard-nosed property provider to buy enlightenment, I guess. I mean, in a sense, you have to build your relationships externally, I would suggest, Jack. And you know, there's a group of GPs down in Stockwell who got very interested in Bromley by Bow. And they've got a very traditional GP practice. It's very small, it's got no extra space in it, but they're very socially minded, and they're in a very deprived community in Stockwell with a high percentage of Portuguese speakers from the kind of mainly from the ex-Portuguese colonies. So very deprived people, many of whom don't speak English, all that sort of thing. And they've created, I would call, a distributed version of Bromley by Bow. So they can't get more in their building, it's just a GP practice. But what they've created is an amazing network of about 40 organizations in the neighborhood, and they are part of that network. So the GP, it's not the GP practices network, it's a network that they are all equals within. And this is voluntary sector organizations, and included within it some, you know, really committed community members, individual members. And this comes together as a network to create health and well-being in the neighborhood. That's not based on a clinical model of health and well-being, it's based on a social model of health and well-being, in which the GPs participate as equal participants along with everybody else. So in a sense, if you're faced with a situation where nobody else can afford to move into this building except yourselves, you have to look outwards and create the Bromley by Bow in an exploded version, if you like, a distributed version of Bromley by Bow, if that makes sense.
Yeah, it does. Yeah, that's really helpful. I guess, you know, it's just frustrating when you're presented with this opportunity to create something. You know, it's in quite a big field, big space that they're doing it. And I think they're only using a tiny chunk of it for the primary care centre. Yeah. It just feels like such an opportunity that it's such a shame that you just run up against a brick wall like that, I suppose.
Yeah. Yeah.
Yeah, just wondering if there's any avenues that you might explore for jumping over those hurdles. I appreciate it sounds like it's not easy, but
and the one that I described, which is actually the instigator, is the local authority who want to build this health and wellbeing hub that I described a little bit earlier, that will have local authority services, general practice and community in it. And you know, one of the officials within the council said, well, why do we need the local authority in this building? I mean, surely the local authority's got lots of buildings in the neighbourhood already. I mean, you know, the local authorities, the voluntary sector is already well established in this neighbourhood. They've got, you know, community theatre, they've got community centres, blah, blah, blah. So why do we need to have them in the building? Let's just build the building with the GPs and the children, families and adult learning provision. And my argument to them is, you don't need the voluntary sector in the building because the voluntary sector needs the space. You need the voluntary sector or because the voluntary sector is going to pay you rent, because it won't, because it hasn't got the money. You need the voluntary sector in this building to disrupt your model. The voluntary sector in this building will be the disruptor of business as usual. There will be the grit in the oyster, if you like, that will create the pearl. And if you don't have the voluntary sector in this building, the GPs will just go on behaving like GPs, and the adult learning people will just go on behaving like adult learning, and the children and families team will just go on behaving like local authorities, social workers. And if we're trying to change the model, we need a disruptor, and the disruptor is the community.
Yeah. Yeah, and I guess your ideas of those breakfasts where different professionals meet as well is good. Although I'm trying to link all of those different services in one breakfast for half an hour each week.
It doesn't matter. Sometimes people rock up and sometimes they don't. You know,
yeah.
If you've done them every 6 weeks, it doesn't matter. You get to see everybody quite soon.
Yeah.
And they're very informal. There's no agenda, there's no notes.
Sure. Yeah. Sorry, I'll stop asking questions now so we can move on, but thank you.
Yeah.
Cheers.
That's all right. Thank you, Jack. Does anyone else have a question before we move on? No?
How's this landing with you, Laurie, and your aspirations around the health and wellbeing hub?
So Bernice, to answer your question, does anyone have any questions? The answer is no. I have about 30 questions, so therefore I haven't asked any of them. Couldn't decide which ones to ask. I've got my occupational therapist with me now, a lady called Lizzie. I don't know if you can see Lizzie now. She's here next to me.
Hiya. Hello.
We're feeling pretty giddy up. We're feeling pretty giddy from what we've been told so far. But we don't want to monopolise the session with questions from us. What we'd be really keen to do is for you to continue the presentation, and we would love the opportunity to follow this up with another call whenever you might be free. So yeah, on that note, we're very interested. We're loving everything so far, but we're going to keep hopefully conversation.
Sounds good. Yeah, we can definitely keep in touch after this. Right, let's move on to just a few pictures of the centre, just to try and give you a little feel of the centre if you haven't been there. So let me just share this now. Right, Dan, are you ready?
Yep, great. Okay, so this is, as I said before, this is the entrance, deliberately non-clinical, and you come into a very beautiful courtyard with sculpture and beautiful planting. The buildings are deliberately domestic in feel and scale. Table and chairs there inviting you just to sit down and kind of, look at your phone or whatever. Or this is an older people's group run there in the summer, so underneath the pergolas with the wisteria and so on. That's called Young at Heart, by the way. That's our leg ulcer clinic patients coming to it's a flower arranging and arts group. So there we are in the snow as well, probably by snow. Yep. And planting and the design. We've had a wonderful architect. This is the entrance to the health centre. Again, no NHS signage, no blue and white signage at all anywhere. That's absolutely critical. We want people to come in to a place that feels like it's a community owned, and it's not. We don't want to condition people's thinking about what you might do when you arrive at Bromley by boat. But this is the entrance to the health centre. There it is again, and so. This is based on a Moorish courtyard, by the way, but instead of being in the interior of a building, it's in the exterior of a building. So we were talking to the architect about this the other day, and he said this is the only building that he knows that's kind of created this Moorish courtyard as the entrance to a space, rather than right in the heart of a building, which of course you get in sort of Moorish architecture usually. Yeah, and lots of beautiful planting, lots of gardening going on at Bromley. This is the health centre. You'll notice no posters up on the walls. As Andrew used to say, nobody reads them anyway. They go, tatty, why not put art from our art groups up on the walls instead? And look at the seating, the way it's arranged to encourage people to talk to each other. This is under COVID conditions, by the way. And so, and this transition from inside outside, and here we have a group room. One of our, and there's a pop-up about social prescribing we just passed. The group room that we just caught a glimpse of is really interesting. I'm sure those of you in general practice will understand there's the group room. We run lots of group activities there. We do lots of work with patients with long-term conditions or parents with young children. I've got a program called DIY Health for parents with young children. And we think the future of consultations is going to rapidly shift towards group consultations from individual consultations. So another thing is that general practice will need far less individual consulting rooms. This is in the church. This is getting ready for an exhibition in the church, actually about our research program. So this is the church is now used. This for a long time the church became a nursery Monday to Friday. It's not a nursery anymore, but it was for about 30 years. One of the things that Andrew did was put the nursery into the church Monday to Friday. There you can see that there. And that was a nursery of equality for the for the GPs and for the local community. This is one of our knowledge share programs. This would be you sitting on those pews if you were at Bromley by Bow on a day like today, and we'll resume these face-to-face knowledge share program events very, very shortly. But this was, I think, a group of Dutch GPs and nurses and physios and occupation. For the COVID months, we've had the food bank at Bromley by Bow feeding about 800 families every week. And that's where the food was stored in the church for about the last 12 months. We've just moved the food out now, actually, as we're preparing to reopen the centre. But yeah, for about a year, the church was where we were storing enough food to feed that number of families. That's the front of the church. One of the things about the church, which I think is quite helpful, is it doesn't really look like a church, actually. There you are. You see lots of this going on at Bromley by Bow. People sitting there talking. That's one of our lead artists and our, at the time, social care manager at Bromley by Bow, having a chat. And where are we now? So that's the park. That's across the park. That's the back of the community centre and the health centre on the right. The cafe's there at the back of the community centre. So the cafe opens out onto the park. And in the summer, we've got lots of tables and chairs in the park. The park is a very active space. There are always people coming and going between the different buildings. There's another shot of that as well. And there's a summer fair on the park. So we use the park as a great way of engaging with our community. We run loads and loads of activities on the park every year. We constantly gardening, of course, in the park. So there's gardening groups all the time. We've got Time Bank as well, and there's Time Bank gardening group. We've got sports activities, we've got a football team, all those sorts of things that use the park. But that's one of our summer fairs. There's an intergenerational tea party designed with the older people's group and a group of artists. So that's why it looks so kind of beautiful and so on. And we've got amazing odd collection of old crockery, for example. That's inside our cafe. That was our Time Bank, having a Time Bank meeting inside our cafe. Our Time Bank had lots of drop-in sessions as well that people would come together in. So that's one of our Time Bank meetings in the cafe, which ran on a weekly basis. That's one of our cooks in the cafe. She actually was doing an apprenticeship at the time. That's the cafe in the evening. So we also can use the cafe for and the areas around it for doing things like evening cinemas and events in the evenings and so on. Exhibitions, do lots of exhibitions and openings and so on, that sort of thing. Conferences as well. We host lots of small conferences at Bromley by Bow. So it becomes kind of really quite a strong community hub and a place where lots of ideas are debated and you know, it becomes a kind of very, very interesting place where people are constantly talking about what the future of health and well-being for our communities is from a very practical basis and very practitioner and community-led through to, as I say, you know, people like the Minister for Health for Singapore and the Minister for Public Health for Thailand, with a whole delegation from Thailand and groups of practitioners and so on who come to Bromley by Bow, and we're constantly discussing what the models need to look like and so on going forwards. And yeah, but that's the connection zone. That's the other end of the cafe. And that's the drop-in place where people come and find out what's going on at Bromley by Bow or what's going on locally. These are our connection zone team, and they just sit there and tell people what's happening. They run lots and lots of groups within the connection zone. So we do small art groups. Some of our walking groups start off in the connection zone. And we've got art activities there. We've got small groups meeting there and so on. We've got a series of small one-to-one booths as well for welfare advice. That's a community fridge. So as well as a food bank, we've also got a community fridge. You can see it's stuffed with melons there. And that's Kate, who manages some of our sort of work on food security and food poverty and so on as well. And that's been a huge issue, of course, under COVID. This is one of our disability arts groups, actually. So the social care program that I described at the beginning is still running all those years later at Bromley by Bow. and it's still led by our artists, some of whom have studio space within the buildings. And the artists are, there's our IT suite. It was actually in point of refurbishment at that point. It's looking somewhat different today, but that's what it looked like then. So yes, IT classes, digital exclusion, of course, a big challenge for a community like ours. Of course, it became even more imperative under COVID to sort of address the challenge of digital inclusion. We've got a huge program going forwards on that, and we have done for many, many years. But yeah, the aesthetics of Bromley by Bow are really important, as you can see from that photograph, I think. That backdrop of the community centre is actually based on the Doge's Palace in Venice, by our architect has told me. So yeah, kind of creating a building with lots of personality, but a building in which everybody feels at home, I think has probably been a real hallmark of Bromley by Bow's design, and the interrelationship of exterior and interior space is really important at Bromley by Bow. And the fact that it's a cluster of buildings that our staff and volunteers and clients are kind of continually crisscrossing these courtyards and walkways and going backwards and forwards from one to another, is kind of, there's always a sense of movement at Bromley by Bow, which I think is kind of really important. Of course, it's a public park, so you know, when school ends, all the children pile out of the school over the road and come and play in the park and that sort of thing as well, and their parents do, and you know, coming on their way home and that sort of thing as well. So yeah, it's a very public space, deliberately so. And there's about 6 or 7 ways in and out of the park. As I say, there's no CCTV. I mean, imagine that being your walk into work in the morning. That's walking across the park. Yeah, and there's a children's playground on the right. One of Paula's beautiful sculptures, which is also a seat, that white object in the centre. But yes, so kind of, it's a very therapeutic kind of environment. Yeah. And there's our gardening group, one of our gardening groups we have community allotments that are garden together as gardening groups, and that's one of them. So, you know, that's a great opportunity for social interaction and have a bit of fun. And at harvest time, you come away with a few carrots or whatever. I've joined the gardening group over the years, and it's been great fun. There's 2 of our gardeners who are on our programme. Yeah, that's Bromley by Bow.
Hopefully that gave you a little idea of what it should look like normally, and also how it looked like during COVID, because we did some of those videos and pictures during the pandemic when we wanted to get some pictures for people to see. Any other question at this point before we move on to the last part of this session? No? Great. Okay, so now we'll kind of move on to the changes. Laurie?
Sorry, we have one. My colleague Lizzie's jumping, if you don't mind.
Yeah.
To ask a quick question. We've only got a handful of people here today that have popped on. If we did want to come back and have a second conversation or drag a few more people to another meeting like this to develop that shared vision, who would be the kind of key stakeholders, the key people you think from your experience that we would need to get around the table to all buy into this vision to make something happen?
I mean, we've done lots of, including actually Well Doncaster, who we worked with for 5 years. We've done well, Berenice organises these things, but we do lots and lots of kind of group workshops for exactly what you've just described, actually, people who are wanting to develop a kind of a model of care, develop a network of people who will buy into it, who will help to develop it and buy into it, and who will then take it forwards and be the people who bring this thing into life. And I think it needs to be said, this is a journey. I mean, I know it's a slightly hackneyed term, but it's not a one-shot deal. It's a journey of unfolding. You know, if you're trying to change a biomedical model of health and a whole set of very, very traditional relationships, which, you know, exist across the country, you know, it's an unfolding journey of development. I would suggest that, I mean, depending on who you know, local authority, health people, public health people, voluntary sector, community members, the local priest or the local imam or whoever it happens to be, who you feel are, kind of might be the credit union, it might be a welfare benefits advice provider or adult learning provider, or some just amazing characters that you know in the neighborhood who are like the movers and shakers of that community. And I mean, I would suggest that it's kind of a mix of people like that that you want to come in and talk about what creates health and well-being in our community, what would help to create a thriving community. If we believe that, and Michael Marmot's proven this, and many others have as well, that 80% of health outcomes are socioeconomically generated, and that only 10 or 20% are generated by the NHS. Then if you start to think about where the weight of if you're trying to create a new model of care and a new health and well-being hub, then the whole thing has to acknowledge that most of what creates health and well-being actually happens in the community. And therefore, the preponderance of your work has to be about working with partners in the community, but it has to be about creating an equal partnership and the acknowledgement by the formal clinical health system that actually the greatest benefit is going to be about improving life for our community out there in the streets and in the homes and on the estates in our community. And how do we do that? How do we build that agency within our community to create a health and well-being? And therefore, they are the people who can help you to shape your model of care more than anybody else, quite frankly. Because it's with them that you want to work afterwards. So that, they are your partners, if that makes sense. Because sometimes we have groups, 20 people get off a train bleary-eyed and arrive at Bromley by Bow, having got on the train in Lord knows where, Leicester, at 7 in the morning, and they rock up and it's all healthcare people. And you think, well, this is great, but, where's your community? It would have been great if you'd brought them along too, kind of thing. And that Leicester example's a mythical, hypothetical one. Didn't really happen with a group in Leicester. In fact, I kept using Leicester as our hypothetical example, partly because I think we've not ever had a group from Leicester actually. So create a mix of people who can give their different perspectives and then work together, because on that train journey down to Bromley by Bow and on the train journey home again. And the other thing I say to them all is, on their way back, when they're saying goodbye at Bromley by Bow at the end of the day, I say to them, you all need to book in a meal in a restaurant for next week. You all need to go and have a meal together, and have a few glasses of wine or whatever, or whatever you want to do. But you need to bond socially, because if you don't bond socially, you won't make this work. It has to, having fun and being a friend. It has to be about doing something that's fun and interesting and enjoyable for you socially and professionally and in every other way. But you have to bond as a group to take this forwards. Sorry, I'll get off my soapbox now, but I think that's what I would say. So you can come to Bromley by Bow and spend a day with us, and Berenice can organise that if you can do that. We've had lots of groups from Doncaster with the Well Doncaster programme with Rupert Suckling.
And are you having visitors in person at the moment? Are you having people over there?
We're starting again, most probably in the course of September, October. So that's definitely something we can discuss. But yeah, I'll pop my email address in the chat in a minute, and then we can kind of discuss this if you want.
Thank you.
Great. So let's move on to the last part about how things were adapted during the pandemic times, what happened and what are the plans forward. Dan, just to let you know, you've got 10 to 15 minutes for this. And then we can take maybe one last question and kind of close off. All right. So you're warned about how much time you have.
I know. You obviously all realize that I could just talk forever, really. Yeah. Okay, so I'll be very brief to give a bit more time for questions. So like many deprived communities, Tower Hamlets was really, really badly affected by COVID. Okay, go on to the next. That's what Tower Hamlets looks like before COVID, by the way. This is the conundrum. There's two bits of Tower Hamlets. Actually, that's the bit where you live, Berenice, the posh bit. I'm not saying you live in the posh bit, but so yeah, Limehouse and Mile End, they're a few hundred yards apart, and there's a 20-year healthy life expectancy gap. I'm not saying Berenice lives there, but the white bit there is the marina, I think, in Limehouse, which is full of very, very fancy flats and yachts and stuff in the marina and stuff. So, you know, but what the point of this is, they're both seeing the same GP, they're both going to the same hospital, yet one group lives 20 years healthily longer than the other and lives for 10 years longer. So it's nothing to do with the NHS. This is to do with socioeconomics. Right, if we go on to the next one. So I won't dwell on this too much, but we put a whole ton of stuff in place when COVID hit. A lot of it was trying to really continue as business as usual, going virtual with everything, virtual classes, virtual welfare advice, virtual employability programs. We had groups of people who had never met, who have made a film virtually, each from their own homes on their mobile phones, and edited it using editing software, and they'd never met each other. They all filmed it independently, and they'd never made a film before. And then we've shown that film. We've done photography projects online, and then put up exhibitions in parks with string and clothes pegs. You know, when social distancing allowed that level of proximity, and so on and so forth. So we, like many community organisations, we were, just like others, heroic in our attempts to try to overcome the challenges of COVID, really. And you know, lots, you know, that the whole voluntary sector, I think, did that and did it wonderfully. And to some extent, we've all learnt a lot from this process as well. If you go on to the next one, Berenice. And then, you know, so yeah, we worked ever closer with our GP partnership, for example. We've created a much stronger, you know, we've intertwined our teams between the voluntary sector, the charity that delivers the non-clinical services, and the GP partners who are our partners. We've created joint teams. We've got a joint social prescribing team. We've done huge amounts of work together on digital inclusion, for example, all that sort of thing. We started to use patient data, very interestingly, to identify whole cohorts of patients who we are now proactively offering social prescribing to, rather than waiting for people to walk into the GPs and be prescribed to social prescribing link workers, for example. So we're building a whole program around long-term conditions where the first point of call is the social prescribing call, really. So that's really, really interesting as well. So we're using data more intelligently than we ever have, actually. We were also able to move very quickly. But then I think Bromley by Bow has spent a lot of time thinking and rethinking who it is and what it is and how it does what it does. We, as the kind of organisation we are, and you know, Andrew Mawson, who's been this prominent figure, Sam Everington's very prominent GP, all that sort of thing. Bromley by Bow's always been asked, what are you doing and how are you doing it? So we have a very, very strong reflective practice within Bromley by Bow, I think, which is helpful from the leadership all the way through the organisation. If we go on to the next slide. So where are we going now? We're doing more and more outreach into our community, actually. We think that physical outreach and connection is really, really important at this stage in the COVID recovery period. We're doing, as I say, a lot of targeting and using really the high quality data that resides within primary care. That we think that there's a huge opportunity there as well. We're building, a lot of outreach, a lot of specialist services to support people who've got needs. Like we're doing a huge digital inclusion program at the moment, for example. And yes, some of our stuff is going online. We will undoubtedly, like all these organizations, we're going to be delivering it in a hybrid basis between physical and online. And we think that this will, I mean, the chief exec of John Lewis said that it shifted things 10 years in 1 year, i.e. that the incremental growth of online shopping, which was about 1% a year growing, that grew 10 years in 1 year. And I think similarly for all of us, you know, Matt Hancock aspires to 50% of GP practice consultations being virtual or used to. That means you don't need you don't need a sink and a couch in a consulting room to do virtual consultations, for example. So primary care estate needs to change as well. You know, that sort of thing. So we think the virtual is definitely here to stay, and it will get more and more sophisticated, actually. As I say, we're doing much more integration. We're rethinking what our primary care network might look like as well, and I'll talk about that just at the end. we're doing a whole lot of training for our staff at the moment about the consistent first contact. We're retraining all of our reception teams within primary care. All of our frontline staff are going through a training program so that we create a consistent and welcoming and social prescribing by default approach to all of our frontline contact at Bromley by Bow. We're looking to integrate the clinical data and the non-clinical data at Bromley by Bow. That will be a long-term program. And the last bit is about the application of the outcomes framework that I already mentioned. So we're applying our outcomes framework. We've developed the indicator set. And this last slide is this notion that actually, you know, sometimes people say, or governments say, or government officials say, you know, blimey, what are the risks of kind of handing over to the community? To which we would counter argue, what are the risks of not handing over to the community? We have huge and widening socioeconomic and health inequalities in Britain that none of our current responses are adequate to resolve. We need to hand power back to communities, and we need to co-produce and co-deliver with communities, practitioners and community together. We absolutely need to rethink the relationship between institutions and communities, practitioners and clients or public or people, and we need to give resources to the community. And through that, you then get, as Bromley by Bow has been, a 35-year learning program of learning and developing our skills and capabilities as a community. Thank you, Berenice. Yep, and hopefully we've got a few more minutes just to take a few more questions.
We do. We have 10 minutes. You did well. We have 10 minutes for any more questions you may have. So feel free to ask away if there's anything that you're wondering and that you think might also benefit the group. Otherwise, obviously, we can take the conversation forward after this. Laurie.
Yeah, I guess I'll pick one from my big list. Is there any other models that we should be looking at for best practice? We know that Bromley by Bow is highly regarded, not just from the community, but from funders and influential decision makers. But is there that kind of, you know, that we should be looking at? And a second question following on from that, where do you see the Bromley by model, where do you see the integrated approach that you've taken, where do you see that going over the next 5 years, let's say? Do you feel like that you're a bit of an exception to the rule, or do you feel like this is the hearts and minds are beginning to see how they could have their own Bromley by Bow in their localities? What's the level of interest and support?
Okay, so that's 3 of your questions. Very good. Where should you look at? Look at the NUCA system, South Central Alaska, if you haven't seen that already. There's a King's Fund paper on it, NUKA. That's really, really interesting. It's more clinical than ours. It doesn't include all the social stuff, but it's amazing. I mean, there are, as you know, Bromley by Bow became the first of what then became 340 or so healthy living centres in Britain that were built under the, well, it was John Major who started the programme, and then it was the Labour government that scooped all the glory, because there was a change of government by the time that healthy living centres started to come on stream. I mean, Tessa Jowell opened our healthy living centre. So there are still the remnants of the healthy living centre programme. There's a bunch of healthy living centres in Scotland, in Northern Ireland, and a few scattered around in England as well. There's a new version in Trafford, in Manchester, called Limelight. If you Google Limelight, Trafford Housing Trust, they built a new version of Bromley by Bow about 3 years ago, modelled on about 4 years of visits that they came to Bromley by Bow to discuss how to do that. That's, I think, the newest iteration of Bromley by Bow. And then there are these ones that I mentioned that we're working on at the moment, but none of them are going to be built for 2 or 3, 4 years, in fact, 5 or 6 years, really. But yeah, those are definitely some examples of systems that you might like, or places that you might like to look at. There is one in Doncaster, a community centre that modelled itself on Bromley by Bow as well. and I forget the name of it, but it's in an old school, and it's got adult learning and it's got a community cafe and all sorts of things in it. And I met the woman. In fact, I visited it, and she came to Bromley by Bow and described it, and she said I'd never been to Bromley by Bow, but I read all about you guys, and I modelled my centre on you guys. And when I went to visit it, it was great. It was a kind of a different version, but absolutely, yeah. It didn't have primary care, but primary care was just down the road. So in terms of where do we see things going, I think our next dream is this thing called the primary care network. At the moment, the NHS has created primary care networks. There's 1,250 of them in England, and they are just networks of GP practices. I think if you think that 80% of health is created outside GP practices, then that makes no sense whatsoever. So our vision of the primary care network is that it should be a network of maybe 20 or 30 organisations in the neighbourhood: housing associations, children's centres, primary schools, secondary schools, community centres, faith organisations, credit union, gardening groups, whatever it happens to be. They should be the primary care network. And we should take primary care networks out of the hands of GPs, and we should broaden it out. It should be a grand coalition of neighbourhood organisations who are all building and creating health and well-being in that neighbourhood, including the GPs, of course. They are critical, but they need to understand that in Tower Hamlets, 30% of our 10-year-olds are clinically obese. For those children, it is already too late. Most of them will carry that obesity through to the very day they die. So they are the diabetic patients of 20 or 30 years' time. If we're going to affect change, we need to affect change in children's centres. We need to affect change with families with young children. We need to affect change in primary schools. So we need the GPs and schools and children's centres to be working together. That was I can't remember your third question, but that was where do we see Bromley by Bow going, and what are the other models? Laurie.
Yeah, wonderful. Thank you. I had myself on mute. I managed to get through nearly an hour and a half without speaking on mute, and I failed right at the end there. But that was great. Thank you.
Okay, so I think reforming. I'm calling them health creating networks or health creation networks. So we need to move on from primary care networks to health creation networks.
Smashing.
Any other questions at this stage?
How about down in Rachel and team down there?
So I've been sort of biting my lip, being a keen advocate of the
going
community.
to say, do you have any? I know
Can
you
you
talked
hear
about
me?
it a little bit, but any more models of
Oh,
the more sort
Rachel's on as well.
of distributed versions? Because I think, as Jack was saying earlier, we've got a practice that is as it is.
Yeah,
We don't have any practical.
Oh, Rachel, you're breaking off. We can't really.
Your screen's frozen,
increase it.
Rachel,
Um,
and your voice.
Yeah, but I think I got the gist of your question, Rachel, which is any more examples of distributed models. The one that I best know is the one in Stockwell. We created an external network. So in a sense, all that we have in-house at Bromley by Bow, that they've created externally those relationships, if you like. We could certainly talk to you about that. And we've worked very closely with them on those ideas as well. I hope that's helpful, Rachel. Looks like Rachel's looking for a better signal somewhere.
Yeah. And sorry, Shelley, you were cut off. You were going to say something about being an advocate for.
No, I completely agree about the community thing and it being more of a, I spent.
Can you hear me now?
A length of time listening to Cormac Russell talking in one of his very inspirational in a webinar, and that's the why is obvious, but how is less obvious. We've kind of been playing with honorary contracts, and we do have some of the charity, the charity groups. We're getting there, but it's nothing like what you've got, and just we just need to work on it, don't we, Rachel? The actual how, I know what you mean, but the NHS was set up the way it was set up, and it's going to take a lot to unpick that, I think. And a lot of the stuff is, you know, we're all working in our silos. I hate that word, but it, you know, and everyone's a bit nervous to change and protective of their contracts. That's the barriers that we come across, and I think we can get there in our down where we are. We've got lots of open-minded people, or lots of closed, but being open-minded and unafraid is to take steps in that direction and welcome in. So we don't have that many people, but I'm trying to get more of these honorary contracts. It seems to work just as long as you've got the rooms, and you're absolutely right about being there and meeting up and doing social things. A little sitting around a bonfire in someone's garden can absolutely work wonders for, you get more value for more, the relationships are much more valuable then, and all of that. Yeah. Hurrah.
Yeah. And you're also right, courage. I think you just have to say, we're going to do this.
Yeah, so that's Rachel. It's a shame that she's not on the screen, but she's quite brave.
Yeah.
I think that she sent me the link for this meeting, and it was nice to see. Thank you.
Yeah, good. Yeah. Yeah, and you know, I think you just have to, I think one also has to kind of carve out some time to do things differently, because, you know, business as usual just eats up all your time. And, you know, I know what it's like. Our GPs also, you know, they come in the morning at 8 in the morning and they're leaving at 8 in the evening. I know what it's like. You just have to say, we're going to set aside some time to work on doing things differently, I think. And I mean, one of the things that our GPs did, and they're fairly large because they've got, you know, they've got 40,000 patients in all. They created a new role. They created a director of the health partnership. They are a traditional profit-sharing GP partnership, but they created a director role who's a non-clinician, who's a big strategic thinker. And that has really helped, I think. I think that's really, and that was about 8 years ago. And then they created an assistant director of population health, and she's a non-clinician as well. And they started to employ a lot of non-clinical staff to work with patients. So we've got a whole raft of staff working with patients within the GP practice, not the charity. I mean, they've basically taken money they might have spent on nurses or doctors, and they're spending it on non-clinicians. And now with the ARRS money, you've got the opportunity to, you know, health and wellbeing coaches, care coordinators, social prescribing link workers. You can have a whole team of non-clinicians as part of your primary care team now.
So we do actually have that. We've got an IT specialist who's involved in personalised care, and we've maxed out on our ARS roles. But I think not heading, so we've had to do the clinical things, but we're getting there, but we're not there yet, and we're not there yet. But we're on that trajectory.
We're about to do a whole lot of work with our nurses, who I suspect are relatively traditional, quite honestly, but, you know, about actually, let's put a social prescribing first approach to nursing. You know, like all the long-term health condition checks, let's build social prescribing into that. The opportunity to detect social need. I love the way the NHS talks about long-term conditions without using the word health, like they make the assumption we all know that it's long-term health conditions. But of course, the joke is that most of the patients with long-term health conditions have also got long-term social conditions. So, or many of them have. So actually there's a win-win there. When you're doing the long-term condition annual or 6 monthly health checks, why not have kind of an open question about how's life and how might our social prescribing link workers support you, for example. And, you know, the other thing is nursing consultations are, you know, they get 15 minutes or sometimes 30 minutes with patients. So they've got more time to have that sort of conversation as well. And they are.
Do you work on group sessions? We're thinking of, you know, it's a bit of a numbers game, but group sessions is something we're dipping our toe in the water with. It's reached a little bit of an impasse with, not an impasse, but we paused for COVID. But
we have an aspiration to move. I can't remember what the percentage is, but like half of our long-term condition work into group work. Yeah. I think it's a misnomer calling them consultations. Everyone talks about group consultations. I think they're group sessions.
Yeah.
that makes, I mean, I think people will still need some individual consultations, of course, to talk about things confidentially. But there's a whole, I mean, there's an amazing program that you can look up on our website called DIY Health, which was group work with parents with young children who had high consultation rates. And we co-produced an amazing program, which has been evaluated and everything, around working with parents around very young children's health and when to go to the doctor and when not to go to the doctor and how to manage your child's health. And as we like to say, the most important feature of that program was getting those parents to swap each other's phone numbers so that they'd go and have coffee together and become each other's social network. And sure enough, the consultation rates dropped away quite dramatically.
Nice.
And that's all on our website. There's a toolkit there. You can download the whole thing. And if you've got, you said, I can't remember which practice it was that said they had a lot of parents with, young parents with children with issues or young families. But, you know, DIY Health would be fantastic for them. And it's all on our website. You can look that up.
Thank you very much. I'm going to have to go because I've got a patient in
Yes,
like, on my list. But hopefully we can touch base again. Thank you.
Yeah.
Sounds
Me
good.
too. But thank you very much. It was really
Lovely.
useful.
All right. Thank you very much,
Amazing.
everyone.
Thank you so much.
By the way, somebody asked, oh, I know what the question was. Are there other people thinking the same thing? So 10,000 people have come on this knowledge share program at Bromley by Bow in the last 7 years from all around the world. So the answer is yes, the whole world has realized that the biomedical model has run out of steam, run out of road, and the whole world has woken up to the fact that we need to create a social model of health. So you're in very good company across the globe.
Dan, just before I go, I'm just, obviously you've got your wonderful website, but I'm just wondering, is there any other sort of resources or things that we can take away from this to kind of share with our kind of organizations to sort of spread the word?
Yes, there are reports, there are two reports that PHE and Wellcome and Health Foundation funded called Unleashing Healthy Communities. There's a full report and a summary report, which are basically what is the Bromley by Bow model. So you can download those.
Are they on your website or do I need to find those separately?
No, they're on our website, yeah.
Brilliant.
Berenice curates an enormous set of resources on our website.
Yeah, I've popped the link in the chat box, and I'll send anyway a follow-up email afterwards with all the links and stuff.
Yeah.
Thank you very much.
All right. Thank you very much, everyone, for coming today. And
yeah,
we're going to sign off now. So yeah, thank you.
And good luck. Good luck with your what you're doing. Yeah.
Brilliant. Thank you very much.
Yeah.
All right. Okay. Bye, everyone.
Thank you.
Yeah. Okay.
Thank you very much.
Thank you.
Bye.
Thank you.
Bye.